So, hello.
Hi, how are you? Welcome.
Thank you so much. I'm from Ecuador, not Colombia.
Oh my God, sorry. Sorry.
It's okay, no worry. So,
Had
thank you
Colombia on
so
the
much
mind.
to Thomas and Alessandro and all the team for inviting us. So, we have this interesting case today. I don't know if you are looking for the big vessel that we have. It's a gastric
Yeah,
varice
we
that
can see your
just bleeding
endoscopic view.
recently. So, we can run the video. So, this is a big vessel. So, this the video was taken today just to show you faster. And now I can show you the EUS view. ¿Puedes cambiar a endoscopía, por favor? So what I do always when I will do a treatment by EUS is to see the vessel. And you can see I am in the gastric area now. And I put water just to see very well my vessels. So the traditional technique is going inside and going here, but the problem is that we have big vessels inside.
Yeah.
And one of the advantages of EUS is that we can follow the vessels. And this is what I do when I do this kind of treatment. So now I am following the vessel, and you can see this is the feeder vessel. So I am at the level of the esophagus now, and I will go going inside here, because you can do it also going inside the gastric varice. But if you do a modified technique that we'll do here, going inside the feeder vessel, you have some advantage that are using less coil first. So now I am inside.
And any
Second, I can
technique
do a
you use to find the feeder
varicelography.
vessels?
Wait. So now I am inside. You can see here. And I also confirm, puedes retirar. Doing an aspiration, as you can see here. So I know that I am inside the vessel. And I do a flush first with saline. And then I do varicelography using contrast just to confirm where I am. And just to see if there is any shunt or any problem, and I don't see nothing. So I come back to US image, please. So now I will use the coils first. And we do a recently publication coil. Necesito un coil de 18, está bien. So we do recently a publication regarding the use of coils, and a randomized study showed that that the combination therapy that was developed by my great friend Dr. B. Muller is superior to the technique of coil alone or glue alone. In this case, to glue alone. But if in cases, if I see, dame uno de 20, por favor. If I see a shunt, I will use just coil.
Okay.
The problem with coil alone is that you need to use more coils. And the second problem is that you have to use, you have patients, the 40% of patients that recover the gastric varices after 3 years of follow-up. So it is necessary to do a second or third treatment when you compare with the combination therapy. So today I will do the combination therapy. I am putting and applying the coils. You can see here.
Both,
Dame otro más.
yeah, fluoroscopically and endoscopically, I guess.
So this is a big vessel. It's more bigger than we see. So I am using larger coils, and I am using a standard spec needle from Boston Scientific 19-gauge needle.
And do you pre-flush the needle with anything, or just because you're aspirating then injecting with dye, you don't need to do anything beforehand with the needle?
Can you repeat the question? Sorry.
Do you prepare the needle with any flush before you go in, or because you're already aspirating when you find the vessel, you don't need to do any pre-flush with saline
Yes.
or anything like that?
This is a good question. I always flush with saline solution.
Okay. And
So
with
this
the
patient
coils,
will need
you
more
always...
coils.
Yeah, it looks
No.
like a large
No.
vessel. I was going to say, do you use the larger coils first until you see obliteration and then add the glue, or what's your technique for how many coils you use?
Oh, how many coils? That's a very good question. So I need to see at least by EUS that there is an obliteration. You can use 2 coils or 3 coils to do a less expensive technique. But I don't believe that is very secure. In my experience, I use more coils, and then I use the glue, because I need to see if there is not flow, at
Towards the
least,
end.
or the diminish of the flow at Doppler, as I am showing you.
Yeah.
Otro más.
And you should have very
So
nice
this is a
way.
big vessel,
Yeah, you should have very nice way of finding
and
the
I am
feeder
in the
vessel.
feeder vessel.
Can you talk a little bit about your technique of finding the feeder vessels? Do you sort of follow the big vessel that you saw in the esophageal area to see where it sort of goes to, or what's the best technique
Yes.
to use? I think that's probably one of the hardest things when you start doing these techniques.
Yes. The thing is, you need to go to the stomach, put water to see very well um, that you are in the gastric varice. Otro más. And then, when you are there, you just follow the vessels until the esophagus.
Okay.
And then you will find, because the feeder vessel, because all the vessels finish in one. It's in rare occasions or rare situations that you have more than one feeder vessel. But it's, you can see also when you are following the vessels from the stomach to the esophagus. Okay, now I think I need one more. So you see very well now at the EUS. Otro más. You see very well now at EUS.
Yeah.
That we have the coil inside.
And just sort of a basic question: do you have your patient under general anesthesia or moderate sedation? Here in the U.S., we always do it under general, but I feel...
I do under general anesthesia. First, because it's a therapeutic. It's better that the patient be in very good condition and then move. Uno más. Y Salina. Uno de 16, por favor. And you need to remember that sometimes these patients could bleed during the procedure, so it's better to have very good control of the respiratory area.
Agree.
Okay.
What about
So I
antibiotics?
am just finishing my last coil, and then I will pass the glue. So we have 160 patients treated by this technique, and we didn't have any until now any embolies for the moment. Regarding the series of Kenneth, who have 3 cases.
But who's counting?
Okay, now this is what? Salida. So I do a flush before to pass the glue. So I'm ready to pass the glue now because I see very well the coils inside by EUS. So I will pass the glue.
And what type of glue are you using? Because maybe the embolization can occur. Oh, we see the glue and we see the obliteration of the vessel now very nicely.
Yeah, and then I flush with saline. So you see here.
It's beautiful.
So now it's a complete obliterate, and I finish. So very good. I will pass just my endoscope to see the gastric varices, but you can see also by Doppler.
Yeah, no, that's really, really nicely done. When will you bring the patient back?
Okay, normally in our protocol, 4 weeks after the treatment, the patients come just for an upper GI. And then 1 year after. Necesito la imagen endoscópica.
So we see it now fluoroscopically, very nice.
Yeah. Imagen endoscópica, por favor.
We cannot see the endoscopic.
Now I will do an aspiration now. An insufflation. La imagen endoscópica, por favor.
So do you give the patient antibiotics?
Yes. Always prophylaxis, just to avoid any. Tenemos la GoPro, podemos usar la GoPro.
Perfect. We see the
So
endoscopic.
I will. You see here now.
Yeah.
So the gastric varices. The difference is that when you put it in the feeder vessel, the gastric varices disappear. Doesn't become hard because the obstruction is behind. You see?
Yeah.
At least 80% of the gastric varices is disappearing.
And it will continue to disappear as the weeks go on. It's very sort of a gratifying procedure.
Yeah. In few days, there will be no more gastric varices. So I finish here. I believe that this is perfect. And I will change the room now for my last case and the last case of today.
Okay, great. So while you're changing the room, I'll just recap on a couple of things you've said. So patient is usually under general anesthesia. For these kinds of procedures, we give prophylactic antibiotics. And the use of a 19 gauge needle, because that's what you can pass the coils through. The coils that we use in the US are the Wilson Cook coils. I believe it's probably similar in Ecuador, not Colombia. And usually you try and find the feeder vessels, which I think is probably sort of the hardest part of the initial EUS. Obviously, if you can't find that, you go to what you see, and that's important. And then you use coils, as many as you can. Start with the longest one in length. They go from 20, 14, and then to the short ones like 5 and 7 centimeters. And here we saw that he used probably 7 or 8, and it was done very smoothly. Other things that you notice that he made look very easy is that the EUS and the needle was always in full view. And that's really important when you do any type of access therapy into blood vessels, into bile ducts, or anything like that.